Morning, everyone, and welcome to the CME session of Teaching Hospital Peradeniya Department of Anaesthesia and Critical Care. Actually, this was a session that we were doing already before in the pre-COVID era, and we just thought of restarting with the help of our head of the department. Thank you very much, sir. Because as a last department decision, we thought of restarting. So as an initiative, I thought of starting, and the others will also take over afterwards. So let's discuss about anesthesia and critical care for liver disease or liver resection patients, right? Because I mean now it's with day by day, Teaching Hospital Peradeniya is getting recognized as a liver center, and major liver resections and liver related surgeries and patients are getting referred. So we all should be geared as a team to handle our patients well and give a good outcome to the patients. So that is the main idea in my talk. So let's see what we can do for our patients. Okay. So what I wanted to take you through was, so let's see what we are going to learn today. So what we want to be able to assess the patient. So these are all high risk patients. So what we are going to learn today is, so which are the intended learning outcomes. We should be able to assess a patient who is awaiting a high risk surgery, and we should be able to do the risk assessment and identify modifiable components in the history and examination, and we should apply remedies, whatever the correctable things, we should be able to do them, and meticulous intraoperative management, and aim for an uncomplicated ICU stay, and we should aim for an early discharge. So let's see whether is it really a challenge to us. Is it a challenge? Yes, indeed, it is a challenge because it is an extensive resection that is going to happen, and especially these are happening on high risk. There is a high risk of perioperative bleeding, because liver is an organ very vascular and it doesn't have any vasoconstricting ability. It all consists of dilated or already existing dilated vessels. So wherever you cut, the cut surfaces bleed. So and also the elderly population is the majority that come across for these surgeries, and also the patients with comorbidities. So this may be the trouble you were talking about. Okay. So and the other problem is yeah, sorry. So these patients are with comorbidities, and also they have nutrition depletions. So most of them are finding difficult to eat and drink, and also they have a lot of nutrition deficiencies which you need to address, and also they have restricted physical capacity because of the disease itself, because most of them are malignancies. So let's just roughly go through what is our liver. So everybody's talking about segmentectomies, sectionectomies, and hemihepatectomies, and so on. So what is this all about? So if you take our liver, it is into 8 segments. Okay, so if you take the right side, the right segments are in an anti-clockwise pattern. So from segment 5, 6, 7, and 8, it goes in an anti-clockwise pattern. If you look from the side of the liver onto the right side. Okay, and then you have your segment 4, which is comprises of segment 4A and 4B. And then here's the hidden part, which is the first segment. In between these vessels, you can see in there, that is segment 1. And then you have segment 2 and 3. And so the vascular compartment is in between, where you have the portal vein, which is the purple color one, and the hepatic artery, which branches out into sides, left and right, and you have the bile duct, and it becomes left and right again, and it becomes the common hepatic duct. So you can see the IVC behind the liver, where it drains the liver through multiple hepatic veins. So you have to identify the risk here, and also the fascinating facts about the liver, because each segment is supplied by branches, so it is easily ligatable and easily resectable. So that's why the liver is considered to be a resectable organ, and by nature it is a organ that can regrow. So whatever the components that we remove can regrow and go to the it can accommodate the size that is adequate to cater or do the necessary metabolic functions for that particular patient. So if you simplify it, you can just relate it to your fist. So on the fist, you can see your fingers. So here, radiologically, the radiology team usually relates it to your fist, where you can easily remember the segments. So 5, 6, 7, 8 anti-clockwise, and 4A and 4B, and 2, 3. So let's see how can we call these resections according to this anatomy. Right? So there are types of surgeries. So when you call it is a right hepatectomy, it involves segment 5, 6, 7, 8 only. So that is a right hemi hepatectomy. And when it becomes extended, we involve the fourth lobe or the caudate lobe as well. And when it becomes left hepatectomy, it only involves the segment 2, 3, and 4. Whereas when it involves extended left hemihepatectomy, it involves a segment 5 and 8 as well. So as you can appreciate, if you go for a right hemihepatectomy and if you compare it with the extended right hemihepatectomy, you all would have seen even with a lesion involving the segment 7, 8, and maybe 6, sometimes surgeons decide to go for extended right hemi. The reason for that is, if you can appreciate, the cut surface is less in the extended right hemi. So what we are worried about is the cut surface of the liver, which can bleed and which can give rise to problems of coagulopathy and so on. So that's why they prefer to go for extended right hemi, provided this segment 2 and 3 is adequate for that particular patient's survival, rest of the life survival. Right. And then, so to further decide on this, we do a radiological assessment to calculate the future liver remnant. So on a CT scan, you can get the whole liver, you can volumize the whole liver, you can get the whole volume and get the right side of the liver and the left side of the liver. So you can see there's a massive hepatocellular carcinoma on this patient's right lobe, where we are planning to do extended right hemihepatectomy. The line is, this is the demarcation, and you can see the radiologists have decided to leave the green zone for the patient, and we do a volumetric assessment of the future liver remnant. So this should be at least 30% of the patient's body weight ratio. So if it is less than 30%, this segment will be unable to support the patient's future couple of future life, and also it will not be adequate for her metabolism. So this is one of the patients we did early July, June somewhere last year, and she was a lady with a BMI of 18, but she did a dramatic recovery with all our meticulous managements, and she's still doing really well, and she's picking up her body weight as well. So, so that is how you calculate the future liver remnant, right? So you are the anesthetist doing the pre-med. Let's imagine a patient. Well, this is a real patient, actually, a patient that we did few days ago or a few weeks ago. So you are the anesthetist who are seeing the patient at the very first, as the very first doctor. So 70-year-old male who was decided to go ahead with the extended right hemihepatectomy. The indication was hepatocellular carcinoma, and he had medical comorbidities. He was a newly diagnosed hypertensive and currently started on treatment, and no history of ischemic heart disease or syncope, but there was significant restriction in his physical activity, and he was complaining of easy fatigability. So this is a very brief history, and I would say this is a very focused history. We don't go into detailed medical histories, we don't have to. We are anesthetists, so we take anesthetic histories. So let's see what we can do. So the highlighting points here is also, although he's a newly diagnosed hypertensive, he had a significant restriction in his physical activity. This can be because of his malignancy as well as because of his cardiac or respiratory cardiovascular compromise. So let's see what we can do for this sort of a patient. So let's see how can we assess this sort of a patient prior to surgery. So we have to take a detailed focused history. Okay, so it will comprise of duration of the current illness and associated features like loss of appetite, loss of weight, and body weakness, and then any chemo, radiotherapy received before the surgery. And because body weakness and loss of appetite, loss of weight is very important for you to decide on the protein content of that particular patient. So or the muscle mass. If somebody is sarcopenic, that means if he's low in his muscle mass, there's high chance for them to go into complications post-op, right? And are there any adverse features like evidence of encephalopathy or hypercoagulopathies? So hypercoagulopathy is very common with malignancies like hepatocellular carcinomas and any sort of liver related or any malignancies precipitating hypercoagulopathy. So we have to be very careful because they are prothrombotic and they can get deep vein thrombosis. So we have to be very careful about the fluid management and preoperative DVT prophylaxis in some patients, and also you might have to put on DVT stockings and calf compression pumps during surgery if it is going to be a long duration surgery, right? And then medical comorbidities like diabetes, are they on insulin? If somebody is more than 10 years with a history of diabetes, there's a high risk for them to have diabetic nephropathy. So if it is not excluded, we have to be vigilant because there's a high chance for them to go into perioperative AKIs. And then hypertension, ischemic heart disease, peripheral vascular disease, CVA, epilepsy, rheumatoid arthritis, heart failure, all these sort of medical comorbidities we have to look into and assess them to see where they are. For example, if somebody has recovered from a CVA, we have to document clearly what were the weaknesses they had and the ticket, right? If somebody has rheumatoid arthritis, you have to take the precautions for the airway. Likewise, so that's the importance of assessing all these medical comorbidities and also the surgical history. So not an inguinal hernial repair or any sort of uncomplicated surgery. What we are worried about is any surgery involving the abdomen, as he had a polycystectomy in the past. So, or whether he has had any abdominal surgeries like laparotomy and so on, because that will increase the risk. The risk of perioperative mortality is high and the risk of bleeding is more. There will be a lot of additions and the hilar resection will be extremely difficult if they have undergone a gallbladder resection or any other liver associated surgery. And we are definitely going to head up with a lot of bleeding. And then allergies and social history. So these things you have to go through in your history. So when you talk about patients, you have to use universal languages, so to grade your findings. So if you can say he's mildly or moderately or severely, but that is not a universal language. Anybody in the world would understand if you talk in gradings. So for example, nutrition, you can talk about the BMI, mid upper arm circumference, then the ASA grades, NYHA classes, and the CCA angina classes. These are all available. So I'm just introducing medcal. Anybody can use it on the smartphone, very easy to calculate. So you get all the gradings done in the medcal. And also not only that, you get the perioperative morbidity mortality as well as a finding of that score. Underneath your calculations you will get that. So then not only that, you have the Darcy Mets. So not the Mets that we talk about, we have to go for the Duke's activity status index, metabolic equivalent of task, which gives the accurate functional capacity. Let's see what it is. So this is the Duke's activity status index that you can see on the medcal. So it is very easy. It's a matter of just clicking on the buttons and filling up. You have to just ask these questions. When you scroll down, you will get set of questions underneath it, and at the end of it you will get the result here, which says 58 points in this case because I have not filled this up. And you get the meds. If you click on this arrow, the med score will pop up and you can get the med score, and it's very accurate. It goes up to even to the second decimal. It doesn't stop at 4, 6 and so on. It will be like 4.28, 5.68 and so on. So if we are unable to do this, at least we should do a flight of stair climbing test in the ward. When we receive a patient, we have to ask them to ask whether they can climb a flight of stairs. If possible, easily in ward 20, we have a nice flight of stairs where we can let the patient climb up and come back. So we can do the pre-test of saturation, pulse rate and the blood pressure, and let them go up on the flight of stairs, ask them to come back and get the saturation, blood pressure and heart rate. So you know where you stand. You can exert the patient a little bit and see how much he can tolerate. So there was one lady like that. Last time we did it's a liver resection. So well, she could not do the flight of stairs. She was managed to do on the level ground, but considering the malignancy and the obstructive features, and we had to go ahead. We told about the perioperative mortality with high risk, and she didn't do well afterwards. She died in the ICU. So these are like, I mean, if you don't have access to these, you can do the flight of stair climbing test, which is very useful. And this was one of her findings for us to say that she will not do well, and really she died afterwards. And also simply you can check the room air saturation as well in your assessments. So if you want to further reassess, actually we have to go for a surgical risk assessment score. So this is a surgical risk assessment tool which I used to use, and it is very easy again. So what you have to do is just on the internet you just have to click as text as NSQIP surgical risk calculator. There you will get this sort of a screen. So what you have to do is you will go to a next page after this, and there you get the set of questions to answer. So it asks about the height, weight, and the BMI and the patient's comorbidities, whether he has had previous surgeries and so on. So when you fill up that form, ultimately you will get a result like this. So this shows the surgical risk of that particular patient. So this is one of the patients we did last year. One of Mr. M's, who's from Nawalapiti. He was a police officer. He came with a again with a hepatocellular carcinoma, and he came for extended right hemihepatectomy. So my challenge was he had a positive exercise ECG. Again, he had a very restricted cardiovascular tolerance. So I requested for exercise ECG, and he was stage 2 positive. So, but despite that, we had to proceed because of his malignancy. And I did the NSQIP, and I found these problems. Unfortunately, this is too small for you. I'm sorry, but I'll share the presentation later on. He had serious complications. So they categorize serious complications as perioperative AKI, perioperative heart failure, major adverse cardiac events. So he was in the yellow zone. So that means he had moderate risk in that situation. And then the other issue is here they show the percentage of this incident happening. So he was in the yellow zone. If you just go by the colors, you can say here the pneumonia risk was so high, it is red in color, and cardiac complications was very high, it is red. So the green ones are less common, it is surgical site infections. And then venous thrombosis, so that is also quite low on him. So then so that was the sorry so that was the finding that I found. And urinary tract infections was yellow color, and various venous thrombosis was green, and renal failure was red. So what I did was, and the death chances were again in the red zone, above average. So the above average ones come as red zone. So, and discharging to a rehabilitation facility, that means he becomes a debilitated patient, was again red. So what I did was I identified the risk. So this predicts the risk that we are going to go ahead and see. So what I did was, so there was high risk for pneumonia. So I started him on incentive spirometer, did a chest referral, got his lung optimized, make sure he had a good hemoglobin, and he wasn't a smoker, and I make sure that he got the COVID vaccinations. So with all that, I managed to prevent a pneumonia on him, and post-op with a thoracic epidural, managed to move him as soon as possible to a chair despite his cardiac issues. And likewise, so I took the precautions for that. So because of this cardiac complication, I got done exercise ECG, and which showed me the targets. So I knew I am not supposed to touch stage 2 numbers. So I was well away from it, and I was stage 1 and above. So I had the targets written on the wall, and I never touched those targets. So by that I prevented a cardiac complication in this patient. So you can see here in the blue box, it says the predicted length of hospital says 7.5 days, but this patient got discharged on day 6 from the ICU. So which was I think it was an achievement for us, because in our setup they say about the hospital say, so at least we could do it in the ICU. So he got discharged on day 6. So that is one thing that I want to really introduce and get into your practice, because it is very useful for us to predict about our patients and be prepared beforehand, right? And then so the other things are, we have to assess the liver. So if most of these patients are with liver disease, so we can do the child glucoses, and then MELD sodium score and UCL score. So all these again available in the Medcare, easy access. It's a matter of couple of minutes work. And then you have to identify the warnings. So if the CP class is more than B or C, it is not considered as a fit candidate to go ahead. And MELD sodium, if it is more than 6, so the scores, if they come up to here, they are considered as high risk. So that is the idea behind, so that we will not proceed with the surgery, or either we have to directly tell the patient, look here, this is your mortality rate, because if they all come with the mortality rates, so you can directly tell them, this is the chance for you to survive, this is the chance for you to die. So if you are happy, we can go ahead. Otherwise, we have to give them the choice, because that is their life. They want to live with the cancer, let them live, right? Okay. So how can we optimize our patients? Now we have done the scorings and we have identified the correctable courses. So nutrition referrals. So we have a nutritionist in our hospital. There's an acting consultant. She's very helpful. We can do the nutrition referrals beforehand and get the muscle masses corrected, correct the sarcopenia, and improve the physical capacity with our physiotherapy team. They are really helpful. They do accept early referrals for physical rehabilitation with exercising and breathing exercises. So all these advices are given and patients can be discharged home and we can get them back after a couple of weeks. And of course, we have to optimize the lungs, a chest referral, nebulization, steam, incentive spirometry, all that need to come into play. And also the breathing exercises. And also you have to address the medical problems like uncontrolled sugar, blood pressures, and so on. And then the anticoagulant adjustments if somebody is on warfarin already. And nephrology input is always needed if there is a CKD or a risk of AKI if somebody is having high sugars and uncontrolled diabetes. So and then the preoperative preparation. So you have to do a selective overnight hydration for patients with high risk of perioperative AKI, and you have to maintain the body temperature at 36 because the livers they bleed, and you have to prevent the lethal triad of coagulopathy. So you keep the patients well warmed overnight with a blanket, and you can get them down to the theater also with a blanket. And as I always do, put the DVT stockings right in the ward and get them foiled when they come to the theater without dropping their temperatures. Keep them covered while the epidural is being done. And so pre-operative investigations, you do the routine, and I would like to suggest to do the serum magnesium and the phosphates because those are the liver related electrolytes. As also this is a good marker of liver regeneration. If we do not have a pre-op number, it's difficult to compare it with the post-op. So we have to have a pre-op phosphate because phosphate will drop in the post-op period if the liver is regrowing. That is a marker of regrowing of the liver in the post-op period. And X-ray ECGs and lung function tests should be done. And when indicated, we have to go for exercise ECGs. And we have to consider whether there are any possible candidates for euvolemic hemodilution, where you do a blood donation on the day of the surgery and replace it with a bag of saline. Please discuss it with the relevant consultants, and you can arrange and decide on the patients who are fit for a euvolemic hemodilution. Right. So it's a big undertake for a patient with a high perioperative morbidity and mortality. So we should not take it lightly. So if you do each step very nicely, we can make our outcome really good. Right. Okay. So let's see what we can. So you know the theater preparation as always. You all are very familiar. So it becomes a little messy theater when it becomes a liver surgery because we need a lot of monitoring, infusion pumps, and then the surgical equipment will also come in like the ERB, resectoscopes, and the argon laser. And we should have double patient warmers if possible, if we are not without disturbing the other theaters. Otherwise, we can foil them and keep them warm, right? And you should have your bell mount by side in high risk patients without opening up the consumables because it is very expensive, but you can always have them ready. And defibrillator, sometimes you might have to have it nearby for some patients. And the monitoring and the NIBP, IBP cables. So in the morning, you can prepare your fresh flushing lines and the transducers once we have confirmed the ICU bed and once we have confirmed from the ward. So then it saves time for us to go ahead with the surgery. Right. So the team brief is very important. Whoever the anesthetist who is there will be the lead in the theater, should take the lead. And before patient arrives, we should do a brief. The surgeon, whoever the surgeon, it can be a registrar, SHO, HO, whoever, that is fine. And the assisting nurses should be there, the in charge nurse, and the junior staff should be there. And the medical students, if they are around, they should learn that. So they should be there as well. So what we are going to discuss is the surgeon will start. He will tell a very brief history, not going to go into details about the histology and pathology and so on. You have to be very focused and just the surgical details. Who is this patient? What is he going to have? Basically, that is that. And then what equipment he needs. So if there's any concern from the nursing side, they will raise it and tell, look here, we don't have this equipment. We have to find an alternative. And then the anesthetist, similarly, we have to tell our concern. So For example, this patient is with a high cardiac risk, so I'm going to have these things. So I need arterial line, central line, vascath maybe, or a 14 gauge cannula on this arm, and please keep these things ready by this time, and so on. And these are the drugs I need. So then the theater will have time to prepare until the patient arrives. And then the junior staff should be aware about all this, because they are the ones who are going to help us, and the nurses. So then they will raise their concerns. They are allowed to talk and tell what concerns they have. For example, if one patient warmer is broken, so we should know that. Otherwise, in the middle of the surgery, we will run into trouble. Right. Okay, so let's see the intraoperative care. So again, meticulous temperature management is important, and lower thoracic epidural placement should be there. And we should provide cardiostable anesthesia for most of the patients. Central venous line, large bore IV access, a 14 gauge is preferred, and it should be sighted upper arm, because you can connect the bell mount to a 14 gauge. You should not try on a neck cannula, because it doesn't work well for the bell mount. Okay, it will troubleshoot, because with the kinking and all, it will always start to alarm. So upper arm 14 gauge is a must, because the vein is straight and it is large. So a bell mount can easily run through a 14 gauge in the upper arm. And then you should select warm saline fluids and 4% albumin and blood and products as needed. So drug preparations, induction drugs, pain relief, vasopressors, and inotrope supports needs to be available. And the morning parameters needs to be checked, like monitoring in the parameters, as well as the blood loss needs to be assessed. So ideally, we should weigh the dry swabs and deduct it once it gets wet. So that system is still not there, which we should look forward to and implement regarding the blood loss. Right. So then the possible intraoperative complications. The number one problem is catastrophic bleed. So because the IVC injuries, the inferior, the vena cava injuries are quite common. Sorry, vena cava injuries. So, and also the refractory heart failures, because sometimes they do go into heart failure, maybe because of deliberate CVP drops that we do during surgery to facilitate the resection, and sometimes because of fluid issues and so on, and or else they are inherited myocardial problems. And AKI is another possible complication, so where you have to get meticulous control over it, probably starting from the pre-op hydration and intraoperative hydration and so on. And you will have to monitor them as well. Metabolic acidosis, hyperkalemia are common, and deranged clotting. And accidental lung complications like pneumothorax, hemothorax is possible, because they are just meddling under the diaphragm. There can be accidental tear on the diaphragm. Usually the surgeons warn us, but if it goes undetected, we have to detect it from our end through the airway pressures and so on. And not an uncommon thing, embolism is possible, because as I showed you all in the previous pictures, the major vessels are just next to the liver. So if there's any tear in the IVC, or if there's any tear in the major hepatic veins, they don't collapse. So they remain open. So there's a chance for us to have an air embolism due to the air sucking in. So those complications are very common. And the other problem is, just under the diaphragm is the liver, and just above that is the heart. So there's very small distance for the air to travel. So keep it in mind. So it is a possible life-threatening complication. Then the post-operative care comes in. So you have to have a safe transfer. Plan out your transfer really well, because this is a high-risk patient taken into the ICU bed. So if they are really high risk, I usually take them directly to the ICU bed rather than transferring from trolley to trolley. And I recommend uninterrupted monitoring. That's why I bring down the ICU monitor and transfer the patient onto the ICU monitor and transfer. So otherwise, there's a massive delay sometimes when we transfer the monitoring into the other monitors. And you have to maintain the temperature at 36 all the time. So keep the foil in place if the patient was hypothermic, and you can keep it in the ICU, and once the patient picks up the temperature, you can take off the these foils. And then the assessment of clotting profile. So if needed, you can go for a rotum. If he has to have a lot of blood and product replacements, we can do a rotum, or you can do a INR, APTT, and platelet counts in the ICU. Then you have to do a goal-directed fluid therapy, where you will need a cardiac output monitor. Not only that, you can use the arterial waveform, and you can analyze it at the bedside, and you can do your fluid according to the goal directed manner. So and the CVP is also very useful. Then you have to do your pain management, not to forget, because we have to maintain the pain management, which will improve and let the patient mobilize as soon as possible from the bed. And inotrope support as needed, you can always titrate, but we usually try to reduce the use of vasopressors, but if the need arises, we are not hesitating, we can use. And terlipressin is another option that we can use if we suspect there's portal hypertension and lot of splanchnic vasodilatation, so that we can divert blood to the kidneys and improve the blood pressure. Right. So, what are the possible post-op complications that we will see in the ICU? Those are the ongoing coagulopathy, bleeding, hypothermia, unstable cardiac parameters, and post-respiratory complications. And also pain management issues. So, the liver failure is a very, very important entity that you should not forget, where the patient can end up with a small for size liver, where if the resection was too much and the amount that was left behind is too small, and if we have given fluid to maintain the blood pressure and so on, there's a chance for this small liver segment to swell and go into failure. That's why we are very careful about the CVP and the venous return and all that. That is to prevent this liver failure that can happen in the future. So if that happens, we'll have to flag him for a very urgent transplant, which is not possible in our setup. Right. So these are the only take-home messages actually I wanted to give. I didn't want to burden you all with anything else. So we'll focus on the pre-op assessment, and we should do a focused pre-op assessment to identify the problems and to come down to a problem list and to find solutions to them, and use the scoring systems and try to start using this ACS NSQIP scoring for any major surgery like esophagectomies, gastrectomies, because for any surgery it suits. This is not only for liver resections, for any major surgery. And always do a team brief. Whoever that is who is there, don't feel reluctant, and ultimately you can improve the patient outcome. So that will be very beneficial. Right. Right, thank you very much. That's all I wanted to tell actually. So, and thank you very much for participation, and if you all have any questions, you all can ask.
Pain relief with the
Yes, sir.
post-op stage after liver resection.
So we go with the epidural. With added fentanyl, we can titrate it to 8 to 10 mL per hour with as a continuous infusion. And if we have preservative-free morphine, we would have given it in the intraoperative period. That will have a long action. On top of that, I usually continue epidural as well. But then, if the blood pressure crashes, we can adjust the epidural, since we have given a bolus dose of preservative-free morphine through epidural. So that is the epidural management. And other than that, we can go for the PCA morphine, PCA fentanyl for elderly patients who cannot tolerate morphine, as 20 microgram aliquots boluses, morphine 1 milligram boluses with a lockout interval of 5 minutes. And other options are ketamine. If somebody is bradycardic, we can go for IV ketamine infusions. And oral tablets or oral supplement, of course, we avoid paracetamol, and I used to give codeine syrup. Syrup is the one that is available. And of course, the local infiltration of the skin, which we can do during surgery with marking if you are avoiding an epidural. So there are many options actually as the pain relief. Uh, Although we don't have here even IV lignocaine, IV clonidine, those are also used in other countries. The other chronic pain management option is to give some magnesium intraop. IV magnesium also said to be elevating the post-op chronic pain syndromes in these sort of patients. So, and also they are deficient in magnesium. Usually the liver patients are deficient in magnesium. So magnesium replacement is beneficial in either way, arrhythmias, liver deficiency, and pain management. If the pain is not settled, we can go for, but then we'll have to be cautious about the sedation. Yes, sir. 3 opioids: fentanyl, morphine, and codeine. Usually we avoid diclofenac, risk of AKI, and then paracetamol. So we can't give. Usually with epidural, they are very comfortable. Most of them were very comfortable, but some need to have supplementary morphine for pain relief. But there's a risk of tachycardia and hypertension for cardiac patients, so we have to weigh the risk and benefit when we start on ketamine.
So post-op nutrition?
Post-op nutrition, usually the first couple of hours we might not start anything NG, but then post-op, I mean, we can start clear fluids after 12 hours, like, and then we just start on the normal feed afterwards, because there have been no bowel resections afterwards. So we can continue on the normal liquid diet or a high protein diet which a patient was already on pre-op.
Now you said extubation is the method.
Yes.
But anyway, in an average liver section, average patient,
Yes, sir.
roughly how long do we expect to keep the patient on?
Approximately 24 hours, sir. 24 hours. Yeah.
That is what is practice there also.
No, sir. They are actually, most of them get extubated post-op. We get most of the elderly patients who are nutritionally depleted and physical capacity is also deranged. So they are unable to breathe spontaneously immediately after the surgery. So most of them doesn't have a muscle mass. NG is a must with hepatobiliary surgeries. The reason is they are handling the upper abdominal organs. So the stomach and intestine get pushed. So there is a, gastroparesis for a little while. So NG needs to be drained and kept draining because of that issue, because it's involving the upper abdomen.
Antibiotics then what are you doing?
The standard practice is piperacillin tazobactam is the dose, is the usual practice. Very, very rarely, if somebody has had previous surgeries and a lot of additions anticipated, we might have to go for antifungal as well, ibuprofen. If somebody is allergic to penicillin, we have to go for an alternative with ciprofloxacin and a combination of penicillin voiding drugs.
CVP targets?
Yeah, CVP targets. Well, I didn't go into details actually. I thought, but then the discussion will be very lengthy. So the CVP target intra should be 6 to 8. So, but then again, you have to carefully monitor the patient if they have any cardiovascular problems. But for a surgeon to, for us to facilitate the surgeon for the resection and to avoid liver congestion, target is 6 to 8. So to maintain 6 to 8, you can do a lot of things like avoid the PEEP during the resection and apply the PEEP post resection. Then keep the head up tilt like about 15 degree on the bed, and then usually surgeons want the patient to be turned from side to side while they are doing, so that also facilitate us to get rid of the compression on the IVC and all. And the other way is to restrict the fluids. So restriction, again, you have to go with your targets and the parameters. The standard practice is to go for 1 liter pre-resection, but sometimes it depends on the patient. If they catastrophically bleed, you can't still go in a restricted fluid regime. You have to go ahead and jump in and resuscitate. But the standard practice for a uncomplicated patient is 1 liter pre-resection, and post-resection you have to be fast on your fluid resuscitation, and pre-resection you allow a marginal urine output. You accept a 0.5 ml per kg per hour urine output pre-resection. Post resection, you have to pick on your urine output, make it to 1 ml per kg per hour, and you have to go for active fluid resuscitation afterwards. Whatever that you didn't give, you can give in the post resection time. That is to facilitate the resection. Then to drop the CVP, you can use some amount of furosemide sometimes just to deload the right side, and you can use vasodilators. Like I used to use GTN spray, although it is a arterial dilator, it paradoxically has some effect on venodilatation as well, and I mean it drops the CVP. So because of that, my one of my bosses taught me to use sublingual GTN sprays during surgery, which will again facilitate to drop the CVP. And failing all that, we can go for sodium nitroprusside to dilate the venous system. So those are the options available to drop the CVP. So you can do many things to drop the CVP actually. Thank you very much, everyone.